Hello, and welcome to Breast Cancer Conversations, a podcast brought to you by survivingbreastcancer.org. I'm Laura Carfang, breast cancer survivor and founder of survivingbreastcancer.org, a nonprofit organization providing community, education, and resources to empower those diagnosed with breast cancer and their caregivers from day one and beyond. Hello, my friends. Welcome to another episode of Breast Cancer Conversations. This is such a cool topic. I am so excited. So before we begin, I want you to think about the last time you walked into a hospital. Picture the lighting, the noise, the waiting rooms, the gowns, the feeling of either being rushed or exposed or overwhelmed, especially if you're already nervous or anxious or scared. Today's conversation is about something we don't talk about in cancer care, the built environment, and how the spaces where care happens can either support healing or quietly add to our trauma. My guest today is Abbie Clary, a nationally recognized leader in healthcare architecture and experience design, whose work spans some of the most influential cancer centers in the country. Abbie doesn't just design hospitals. She designs systems, workflows, and cultures that shape how patients, caregivers, and clinicians experience care. Today, we talk about why hospitals were historically designed for the, quote, default male, and how that impacts women, especially those navigating cancer care, and what trauma-informed, survivorship-centered design can look like instead. Welcome to the conversation.
My name is Abbie Clary, and I am the Executive Director for Market Strategies and Growth for Health for All, which means I am focused not only on design and problem solving within healthcare institutions, but also looking, 20% of our healthcare happens at institutions, but the rest happens outside of institutions. So how can we use our design and creative problem solving to affect health within the walls and outside of the walls of institutions? So that's my job. I do travel a lot because healthcare is everywhere, and you have to find the places that we want to make impact everywhere. So today I'm in Denver because we were meeting with a client here yesterday, but every week I'm someplace different.
Oh my gosh. And how did you get into this field? I didn't even know this was like a sector.
Yeah. So when I finished college or graduate school, I did not immediately find a role in an architecture firm. So I found myself at a place that back in the day, all of the drawings for hospitals were done by hand, and that's all they had. So I started with a company that was digitizing it, so drawing it in AutoCAD. So all I did was measure hospitals and draw the hospital plans, which was mind-numbing. But I ended up learning a lot about hospital like codes and that type of thing because I had to in order to do the drawings. So when I eventually did find a job in an architecture firm, they said, "Oh, you have healthcare experience." So that's where they put me. And I'll tell you, it didn't mean as much as it does to me today in the first, 10, 12 years of my career. Back then, it was, you kind of went to the physician or the nurse or whomever, and they just told you what you wanted or what they wanted. And then we went and drew it. Like we weren't any sort of we were architects, experts in architecture, but we were not experts in healthcare and health experience, like that type of thing. And then in the early, around 2010, I pursued a project called the Shirley Ryan AbilityLab in Chicago, which is now built as a 27-story rehabilitation hospital, inpatient rehabilitation hospital. But the CEO was this incredible woman named Joanne Smith, and she had this vision around connecting patients with the researchers so that the researchers would have more empathy around the work they were doing and see the people that they were doing it for, which might affect how they work, might affect, impact the need or the desire and the passion around what they were doing and maybe make them go faster. And that changed how I was seeing things, right? And plus she was just inspired me completely. But during that period of time then, I realized there was so much more to what we could do as designers because she figured out how to do more. So we ended up designing that building to support that concept, right? The building is beautiful, but it was a backdrop to making these impactful things happen. And that was the day I was like, wow, being a designer for this is way more than being a designer. It's also being this advocate for all of these people who need these spaces and need these treatments.
That's incredible framing. So, the background and pursuit was really behind architecture and you
Mm-hmm.
just so happen to land in healthcare and then really then lean into the healthcare sector. So it's not like you woke up one day, you're like, here's the answer, right? This is
No,
exactly what
no,
society needs.
that never happens to me. No,
That's
no. And it's
reassuring.
been,
Sometimes I think everyone has it like figured out. And I'm like, okay, how do they do it and
yeah,
not me?
no, it's been trial and error ever since. And it's been wonderful because every day there's something new for me to do better.
Mhm,
And so I love it. Yeah. I never knew that this would be where I was. My
mhm.
thesis was a airport. So,
Okay. Which could use
so
some love too. Like,
yeah,
don't get me
that's
wrong.
true.
Yeah.
That's true. Well, and that's health, right? Like we should be designing airports for people who are traveling to have health and wellness. I mean, there's so many things that could be better in airports for that. So
Absolutely.
yes,
No, I
agree.
recently learned that the soft background music in some airports are intentional because they want to like kind of lower your anxiety around like delays or travel, or just all the airport anxiety. And I was like, oh, that's nice that they play nice soft music back there.
Yeah,
Maybe subconsciously it's helping something. I don't.
smooth jazz.
Exactly, exactly. You mentioned something that I was really interested in to kind of learning more. So you mentioned about 20% of patient support and care is happening within the walls of the hospital or the institution and clinic, but 80% is happening outside. Can you tell me what is the outside?
Yeah. So there's the social determinants of health, which are where you sit within the socioeconomic conditions, right? So we know that people who are in lower socioeconomic conditions tend to be living in areas that might have not as clean air. So then there's more chronic asthma. There are people who don't have access to food. So there's food deserts. So there's all of these other aspects of society that affect the opportunity and ability to be healthy. And so, how can we get out there and solve some of those problems? Like children having access to exercise, parents having access to daycare for overnight shifts. Like social wellness is as important as physical wellness because, the brain and the body, they are connected. And so, that's what I mean. Like, you gave me the example of your brother looking to create bike lanes wherever he goes. That is a health solution by design, right? So thinking about those types of things, thinking about how we can bring more health, wellness, mental and behavioral health overlay into education, K through 12 schools. A lot of people just don't understand that that can be all integrated with learning. So, level of oxygen in education improves kids' ability to learn. So we can just look at infrastructure. So there's a lot of places to affect how we live that will ultimately affect our health. And in my world, it's all about impact and wanting to help, right? And so I want to go to those places that is the food desert and figure out how our health and design can help solve that through community planning or partnerships with the health institutions I work with and that type of thing.
Incredible. Thank you for framing that. And I think next time I will invite my brother to help with this podcast conversation because
Yeah.
it's totally aligned. And
Yeah.
it's definitely a world that I know very little of, even though all of us are living in it. And
Mm-hmm.
now that you're mentioning these things, I totally understand these examples. And I'm very fortunate to be living in Boston at the moment. And so when I was diagnosed with cancer, I was like, gosh, if I'm going to be sick, at least I'm in Boston and I have access to some of the best
Mm-hmm.
in the world's cancer clinics and support resources and just access. And then you think about, we use a very similar statistic. You think about the coasts and some of the bigger cities that have these great NCI designated cancer institutes, but what about the 80% throughout the rest of North America or the United States alone that don't have access? Or even thinking about, a specialist, in this case, breast oncology versus a generalist, et cetera. And so all of these things kind of play into, how can we create this design? And as you were mentioning, health for all, which is so critical. So I would love to like dive in a little bit more. Like, I don't even know where to begin and talk about design. I'm almost wondering if you want to walk us through like a day in the life and when
Mm,
you meet with a client and are looking at hospitals. We were talking about airports earlier. I think hospitals are also very anxiety driven, and
absolutely.
especially for us in the cancer space. And we talk a lot about trauma informed architecture, design, and trauma informed support because you go there and you're like, gosh, this is where it all started. This is where I got that biopsy and they told me and delivered the news that I have cancer. Now I'm going on a weekly basis for infusions. I'm going on a weekly basis trying to coordinate my own scans and blood work and follow ups.
Mm-hmm.
I think at the beginning, at least for me, I was like, okay, this is like, it's on the calendar. I have to make a priority. I'm doing this. But by week 12, I was like, gosh, I know that I'm like bringing myself to an infusion center I am giving myself incredibly toxic chemicals. I know that this is going to cause diarrhea, headaches, nausea, fatigue, and I'm doing this willingly, walking through the numbers, and I'm early stage with my cancer diagnosis. I know those who are living with a terminal or metastatic disease, there is no end. I was counting to get to week 16, week 18, and then there was going to be light at the end of my tunnel. But for so many patients, there is not. And so how do you keep that stamina and that will to keep going with, the bright lights and just like kind of the sterileness of the hospital? So let me pause there so you can react and respond.
Yes. So a couple of things. So one, you described what being a cancer patient is really well. A lot of times we talk about, we have a graph that shows kind of a line that goes like this. And on this line, a patient diagnosed with other type of illness goes once, gets some treatment, they go once more, get some treatment, and then like a year later, they go once more. When you put that line with cancer patients, there's like 100 dots on it, right? Because they are coming back over and over, maybe for their entire life, right? So how you treat space for that repetition has to be different, right? We also, as part of our design process, we do behavioral research. So we'll do sort of ethnographic one-on-one interviews. We have sometimes followed patients. And what that is about is that we understand how to design the workflow of a cancer center to be efficient for the nursing staff and physicians. But what's missing in that efficiency, a lot of organizations say, oh, efficiency is good patient experience because we're getting them in and out. But they are missing the entire emotional aspect of being a patient. And so some of the research, which will not be a surprise to you, but was really good for us to learn, we did on Memorial Sloan Kettering. We're doing their new 20-something story tower. It's a new cancer pavilion to tie together with their hospital. We did this type of patient and staff research with them. Some of the things that we learned was, one, that first visit is you've learned you have cancer, but you don't have your treatment plan yet. The anxiety and anticipation of that visit is enormous. When the patient and their family or whomever's with them arrive, they can't see anything, they can't hear anything. Like there's no, like, it's hard to take in information because you don't know what you don't know. And so when we design space for that first arrival, and when we design operational care models and workflow, we take that into consideration. We have to make it so simple for that patient and their loved one to get where they need to go and to get to that treatment plan as fast as possible. At University of Chicago, we're doing their cancer hospital there. And one of the ideas we had was this thing called Launch for that first diagnosis that would bring the patient, would come to one place and they would have their treatment plan made that day, but they don't have to move around the campus. They can stay in that general vicinity, like on that floor. They may have to move around the floor, but almost everything could come to them. I don't know, I could bring an MRI to them, but the rest of it is there so that they can find, their control of themselves. That's another thing that we've learned is that control is incredibly important. So in anything that we design, whatever we can give to the patient to have control over, because you don't have control over your cancer diagnosis or your future, right? Like you're doing as much as you can. But if you can have control over other things within that journey, it gives you confidence and gives you like grounding. Gosh, so many other things like with staff, right? So it's hard. It's hard to be a nurse for cancer patients, especially because of how many times you see them.
You're just
You build
delivering
relationships
again and again and too.
Yeah. And these become people like that you've been treating for a long time. So you also have relationships. So we learned that nursing needs someplace, like we call it, take the badge off. And because they don't want to show their emotions potentially in front of the family, whether they're good emotions or bad, something good may have happened to them in that day, but it's not appropriate for them to be excited and laughing in the moment, right? But I think that the ability to, and when that emotion happens and something is hard, they're doing that like in the stairwell or in the bathroom or, in a break room with all of their other staff there. So thinking about how we create space for that dignity for the staff too, so they can have that moment without their badge and be a human being and express whatever it is. So those are the types of things like the research brings to us, but then that's how the environment can really affect, hopefully, the emotional outcome of that patient along with the clinical.
Wow. Oh, that like gives me goosebumps too. You brought me back to like that day, right? Walking in.
So hard.
So hard. And I remember too, like the family, like my family's all spread out and, my husband came with me and my mom flew out because she wanted to hear what the doctors had to say. And it was like, kind of show up with this entourage. You're trying to be strong. You're trying to navigate a hospital, which, no matter how many maps they give you, you have no idea how to
Right.
navigate
Totally. It's never easy. No.
in that space. So
Yeah.
critical. But I'm
Yeah.
sure too, these are like the subconscious things that affect us when we know it's not working, but we may be blinded by when it's really going well and kind of
Hmm.
subconscious that was really easy. There was that welcome desk when we came in and they would directed us to where we need to go, or something as wonderfully coordinated as bringing your care team to the room that you're in so you don't
Hmm.
running around going to see all these new
Yeah,
buildings.
because that just causes more stress. And you bring up your mom and your husband. Something else we've learned is that it's really important in our care models that because we don't just design buildings, we design the workflow that the patients and the staff move through. We design the actual care model. So like that idea of launch, that's a care model. So we design that. We design and identify the enabling technology that's going to make the experience happen. And we also then do the environment that supports all of that. So all of those things have to work together in order to create an experience, right? An experience isn't just the building. You bring up your mom and your husband. One thing that we learned is that the caretaker, the loved one, isn't along for the ride. They should be considered part of the care team. They should be part of that clinical team because your example, like you are trying to be strong and trying to hear everything. And but you're not, right? So they have to be your eyes and ears, but they also have to be regarded that way by the care team. So how do you change culture in an organization, as well as what kind of spaces does your husband need in order to participate in that way, right? Rather than just being there to support you as a loved one. So another really important aspect of that entourage that you
Yeah,
bring with you.
absolutely. What's interesting, and I know this isn't the case for everybody, I was incredibly fortunate to have the amazing husband that I do, to validate exactly what you were saying, where they're part of that care team. When we talked about my diagnosis, he always used the words we. We have
Mm.
cancer. We have an appointment
Oh,
coming.
that's
We have
wonderful.
surgery.
Yeah.
And how, again, I didn't put two and two together necessarily. You're in the thick of it. But in retrospect, I'm like, wow, he really, like, this was an us thing. Yes, I'm the one receiving treatment, losing my hair, the one feeling sick and nauseous, but it was a we experience going through the cancer.
Yeah. Yeah. And you don't have to know it's easier than you think at that moment. That's not what's important is that you can focus on yourself, right? And not be worrying about anything else.
So hearing all of this described, I'm like, yes, 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 sign me up. If I was the CEO of the hospital, I was like, yes, go forth, build. This sounds
Yeah.
amazing.
Yeah.
What type of conversations, resistance, or negotiations do you find yourself making? As it sounds like it's very much a collegial, collaborative learning from both sides. You're bringing your expertise, and I'm sure the hospital has their own ideas or models of what they think is the most efficient way of designing some of these spaces. Are there like aha moments that happen in these conversations or anything that you were surprised to hear or learn?
Well, okay. I think I'm going to go to the challenges. Healthcare, as I think all of us, all your listeners know, is really super complicated. The entire system is set up in silos that don't talk to one another, and we're in there trying to affect like this part of like this gigantic place, right? And healthcare institutions are very, very conservative. So there are times that we come to them saying like we need more space in order to accommodate some of this emotional and behavioral parts of the journey, but it costs more or it takes more time.
Yeah.
And sometimes that upfront cost gets in the way. We try really hard to help our clients understand sort of the long-term return on that upfront cost, but sometimes it just doesn't work. And they're also very used to like what I said earlier around Uber efficiency. And when we do Uber efficiency, it is shrinking the building and making everything kind of just in time. It sort of leaves the patient out a little bit, but it does help them from a business perspective to live within the margins because they don't have great margins. I mean, we know that for sure. So there's definitely those things that get in the way. But part of what I try to do is educate them around what patient's experience really means. And that description I made of like all of these things happening together affect outcomes, right? So they affect outcomes for patients. They recruit and retain staff if we're doing the right things for those staff and burnout. So there are maybe not upfront savings, but there are long-term benefits to doing all of those things. So that's probably their aha when we when we help them recognize that it actually benefits them in other ways that might not just be the upfront dollar.
Thank you. Thank you for sharing that. Because, there's always two sides to all of these stories, probably more than two.
Yeah.
And so it's kind of thinking well-roundedly here. What have you noticed, or have you noticed anything as it relates to patient experience or even provider staff experience and gender? Do you find that, gender plays a role in how some of these designs are being developed?
Wow, you've opened the floodgates.
Please.
So I wrote an article or a blog, or I don't know what you want to call it, a thought piece recently about what's called the default male. So over the last hundreds and hundreds of years, somewhere when we began, the male was considered the default and the female was considered the outsider. And you see it I'll just give you a simple example in language, right? So let's see, I won't use Spanish. So in English, let's see, so actors are everybody, actresses are the women. The national soccer team is the men's. The national women's soccer team is the women's. So it's always the outlier. And then in the 1960s, our government developed what was called the reference man, which is like a 5'9", 100 and something pound, 20-something-year-old white male. And this is what they use to start doing safety and health research. So, and I don't know, but your audience should know that majority of science research has been done on male bodies and then applied to everybody else. Again, see, default male, outlier. And so all of that reference man then really it became everything in our society. So even codes have been developed, building codes have been developed based on this reference man. So examples like ladder rungs are made for a man's step. The number of steps that we have to have to an exit are made based on a male gait. It's crazy. And you don't notice it. I mean, it's just there. It's just embedded in our society. So when you look at any space, but especially healthcare spaces, they are made for the default. And I can take man out of it. They're just made for the default that was born this way with us as the outlier. So that has to change, right? We're different. We just had at my company 2 days ago, we had a morning charrette with a big group of women, designers and administration people from our office. And we talked about healthcare and design for healthcare for women and what we would do differently. And one example someone brought up that I never thought of was those clear plastic bags that we carry all of our clothes in when we go in for, any sort of treatment. And they say, put on this gown, put your stuff in the plastic bag. And she said, I don't want a clear plastic bag because my bra's in there, my underwear's in there. And I don't but that's very particularly female, right? Nobody's thought that's design. That's part of our experiential design. So, and I'll tell you a short story. What woke me up even more to it was I had my own treatment. I was having heart palpitations because I can feel my heart beat in my chest. It's weird. I won't even explain it. And everything's fine, but I was going to find out if everything was fine. And so I went and I had to do a cardiac echocardiogram. I think that's what it's called. So I had to run on a treadmill and then I had to lay down on my side and they put ultrasound on my chest to see how my heart does to go back to resting. But what was awful about it is I came in, I had on my sports bra and sorry, audience, I hope this doesn't offend anyone, but I'm double D and ready to go, right? Ready to run. And the technician said, you can't wear that. And I was like, I can't wear the sports bra. And she said, no, because they couldn't get the nodes in the right spots. The sports bra got in the way. Yeah. And I was like, wait, you're telling me that I got to run for 10 minutes as fast as I can in the gown, those gowns that don't fit us. And then lay down on that bed and that guy over there is going to you know what I mean? It was just, and it was humiliating. I started crying. And luckily the technician was a woman and she totally got it. And she actually asked for another female technician to do the other part. She couldn't solve any of the rest of it, but she at least had the empathy and connection with why I was feeling so humiliated. And so as I'm running on the treadmill, holding myself, I'm saying to them, this isn't the way it should be. We should be designing this differently. And we had this whole conversation during the whole thing about how the procedure wasn't designed for a woman. The gown wasn't designed for a woman. The room, craziness. So now I'm on this rampage to try to figure out what that does mean. And I don't have the answer yet. Still trying, but we heal different. We have our emotions obviously are different. Our bodies are different. We have things that happen to us that men can't even understand because they don't happen to them. Our period, menopause, all of those things. And so that's a place where we should be designing differently, because it's the outlier. Let's design for the outlier.
Wow, I really appreciate you opening up and sharing that personal lived experience that you had, and way to utilize your 10 minutes on the treadmill
Right?
by advocating and making change. So I love that. And my listeners and people in our community hear this all the time from me, but I was like, it is really hard to advocate for yourself when you are feeling vulnerable, you're half naked, you're on a Johnny, and you have these like wires attached to you, these IVs, they're pricking you with all of these needles. And that's when you're supposed to say like, oh, this isn't right. This isn't a good fit for me. Right. And
Right,
so
right.
you understand how challenging and hard that is. And the fact that the person with you is able to not be able to change everything, but at least accommodate something in that moment is really beautiful. I remember waking up from surgery and, they don't let you relax. You're just getting out, you're dopey because you've been on anesthesia, you're just waking up. And I remember my male surgeon, who I loved and was fantastic, would come in every 2 hours, but started bringing an entourage of male fellows to show the type of surgery that was performed. And at one point, I was like, okay, I know I'm kind of like unconscious. I'm still like coming out off of like all this morphine and, anesthesia. And these people are just like opening up and looking at my breast. Like it felt very, very invasive. And that
Violation. Yeah,
Yes,
totally.
exactly. And you're like, okay, I'm a human first, but now I'm a specimen kind of on this bed being opened up and looked at, random hours throughout the day. And it was very, very uncomfortable. And, not to stop science and learning, but at the same time, I'm like, at least give me 24 hours before we decide to like look at all these wounds with an entourage of people.
And ask your permission, right?
Yes.
I mean, that alone is providing dignity in the choice, right? The other thing that's unfortunate is there exists a lot of unconscious bias around women and healing and pain. And we are consistently dismissed in healthcare with regard to our pain, honestly. And Black and brown women are dismissed like 2 times more. So it's also something that we need to work into our medical schools and our training for our physicians and nursing, that exists. I mean, we all have unconscious bias. It's something that, we didn't choose to have. It's just the way it is, but we need to have awareness, right? So when we design experiences, again, we're working with the client to make sure that they're designing or changing their culture. So part of what our design team can do is actually do culture change management as part of the implementation aspect of design. So we're not only designing and building the building, but we're also training and changing the culture to align with how we're designing the building. Because the worst thing that can happen is and this has happened to me, we design the building for a specific care model, for a specific workflow and a culture, and they don't do any of that. And then they move into the building, they use it how they used to, and then they hate it. They hate the building. They don't think it works because they didn't do all the other things that the client needed to do in order to make that change. So that's why we try to help that aspect of it too. So it actually works.
Yes. Wow. You're like full service, whole.
We are full service. Yeah. Like I don't characterize our firm as an architecture firm. It's really a design firm because we have so many different services to make that design work and it's not just the built environment.
What's next on the horizon in this new field that I'm just discovering? One thing that I find really interesting from a patient perspective is a lot of times change can happen from the top and the bottom, not to put the patients on the bottom, but when we start asking our doctors, like, tell me about that clinical trial, or tell me about this new test, or tell me about this new X, Y, and Z, that's like the advocacy piece of ourselves. I'm now, next time I go to my doctor's appointment and they want me to change, I'm going to ask for a non-transparent bag for my clothes.
Yeah.
Are there other things that we can be asking for to also like have the light bulb go off for them to say like, oh, wait, there's this thing that's happening and a cultural change, a shift, more inclusive environments for women's health?
There's a lot of things that I've learned about the healthcare providers. It's important to have a healthcare provider that you can see yourself in some ways, right? And so I mean, I'm not an expert in choosing healthcare providers, but I do see a lot in picking the person that represents or has knowledge of sort of your background and your culture, which, makes it harder for some cultures that don't have a lot of healthcare providers from their culture. Like, I mean, I don't know what the percentage of African-American physicians there are, but I know for women having babies, there's there's not a lot of them. And so they're not getting access to people who can connect with them. They're getting access to someone who doesn't understand. So I do think that's important. Things that are coming, I mean, honestly, in cancer, the rate of change in research and ability to catch cancer early, to be proactive and know even before you get it, to treat it and actually have success in eradicating it. I mean, those things are happening right now. And it's incredible and I love it. And so one thing that we need to think about is designing rather than for reaction and treatment, designing for survivorship and starting with that in the beginning, like designing for longevity, right? So the decision you make today in your treatment is a decision that is best for you in survivorship instead of it's just best. It's like that upfront cost, right? Like, let's think about what does longevity mean and what is the thing that we need to do now to make that longevity the best, right? So I do think that we are starting to design cancer hospitals and cancer campuses with that survivorship aspect in mind, because there's going to be in like 50 years, there's going to be a whole lot of people that have cancer as a chronic disease instead of, a death sentence. And that means that our campuses need to be able to evolve over time and go from sick care to well care, or have a combination of that on the campus, or be able to, like right now, it might be 50% sick care and 50% well, but eventually become 20/80, right? And so design also is in the flexibility we make to be able to evolve without having to tear down and rebuild, right? So that takes a lot of work too, because you need to design that into the plans and into the long-term plan. So that's something we're thinking about a lot.
Well, you make me excited for the future. And
there's so much good stuff happening. I mean, it's really quite incredible.
Even thinking too, I remember like during COVID, prior to, cancer changing my life trajectory, my background is in education, was working in higher ed for a number of years. And, I remember during COVID, there's this whole push around, obviously, and so is like virtual. And then a lot of discussions around, the bricks and mortars and institutions and how we're educating our learners. Hearing this now, where we're talking very specifically about the physical structure, the bricks and mortars and the plant, the architecture, the design, the buildings is just really interesting to me to think about too, and kind of like that virtual environment where we can log on to the patient portal and read our diagnosis, versus physically going to the hospital or the doctor's office or the clinics.
Yeah, we call that the phygital environment. So the importance of, we have a digital environment, right, where you can check in and see your diagnosis, and we have a physical environment. How do we make sure that those go together? So we have phygital because it's digital and physical. But that's one experience, right? I mean, you're going to have both things. They have to be tied together. Yeah. Something else that is a huge challenge that's not cancer related, well, it is cancer related, is mental and behavioral health. And the state of humans today with regard to mental wellness, and finding, we do a lot of mental and behavioral health design work as well. And I find it really important to have our experts in that field as part of the design team, so that not only are we designing the patient experience around their anxieties, but also what we know around mental and behavioral health, and those things that we need to overlay to make sure that is an aspect of the design that's important. It's unfortunate because the government doesn't reimburse mental and behavioral health services very well. And so that's why there's so little of them. And that's why they're hard to find, especially for people on Medicare and Medicaid. Like, if you're a payer and you can pay for it, you can find it. But if you are not, it's very hard to find.
Disparities in access is huge.
Yeah. So we really want to focus on making sure we can get as much of that into the work we do as possible, so that it can influence where it can.
Abbie, this has been an incredible conversation. What haven't we covered that you want our listeners to know, if there's anything? And then I have one more fun question for you before we wrap things up.
I would hit advocacy. One, as a woman, it's hard to advocate for yourself sometimes, but I strongly encourage everyone not to say I'm sorry all the time, and advocate for yourself and don't feel bad about it. Do it, because we are a big part of making that change. And I just don't back away from it, and don't let people feel like you're being something that you shouldn't be. So advocate for yourself. And then I also think it's really important to advocate for others, and do that as much as you can, right? Like, I don't know if you know what a doula is.
Yes.
Yes. So for your listeners, a doula is someone who is an advocate for a woman who's having a baby. And all that person does, the doula, is advocate for that woman's health and the baby's health. So I would like to have a doula in everything I do in life. but we need to be that, right? And so in whatever the work is that you do, so I advocate through design, but advocate through the work you do, right? Find ways to make impact through whatever it is you do for a living for other people.
Amazing. And we've actually done podcasts and webinars on doulas as it relates to end of life. So we think of doulas a lot in like the setting of birth, but then also there are these amazing advocates to be by your side to advocate for the wishes of the person who's also transitioning from their physical life as well.
Yeah.
So we definitely need advocates. And you're
Very
also
powerful.
reminding me, this phrase of like being the CEO of your health, being the CEO of your health. And one of my dear friends reminded me that when we go and we're having a discussion with our doctors and they're providing us with all of our treatment options, it's our decision. They're all our consultants. They're consulting us with what the treatment options are, the standard of care, the experimental opportunities. At the end of the day, it's our decision because we own that. And a lot of times too, to go back to some of like your gender comments or the experiences of patients where there's dynamic between the physician and the patient, the role that one's background and ethnicity and upbringing kind of bring into that as well. Are we allowed to even question what the doctors are do as the
We
authority?
question ourselves.
Yes.
Yeah.
Absolutely.
Yeah. If you don't feel comfortable advocating for yourself, then bring someone with you. Like my best friend, if I was in an uncomfortable position, I would bring her with me because she would say everything I either didn't think of or was afraid to say. And so find somebody, right?
Exactly. There's plenty of us out there ready to.
Ready to. I'll be there.
Amazing. Well, I really loved this conversation. My fun question for you, and I always try and come up with like a fun question for at least somebody to understand, like, what are you reading these days? Like you mentioned that you were reading or publishing some thought leadership, but are you reading like what's on your desk right now or in your Audible that you're listening to? Or
currently holding my computer up.
Fantastic. Okay.
When Burning Man Comes to Washington.
Ooh, John Singer. Okay.
Yeah. So it's a field manual for writing chaos. So it's really a workbook. Like it's about, we're in a new age. We're in a place where everybody's looking back, trying to be what we were, from a business perspective, from a government perspective, from just life perspective. Everyone's sort of got this nostalgia for what used to be. And the book is about like, it's not going to be that anymore. So get on board with it's not going to be like that anymore. And then how do you use today to build a better business and hopefully a better world? Like, how do you ride this chaos and use it to do good things? So it's about advocacy, I guess you could say. It's just how to do it today versus stop trying to do it like you used to, because it's not going to work anymore.
Yeah, we have to evolve for sure.
Yeah.
Abbie Clary, this has been so fun. Thank you so much for joining us. And thank you everyone for listening to our show. I would like to acknowledge that all of the information on our podcast is from personal experiences and is not a substitute for professional medical advice. You should always contact your medical care team. If you are looking for specific topics or would like to be a guest on our show, please feel free to reach out. My email is laura@survivingbreastcancer.org. Our show is made possible by our nonprofit, survivingbreastcancer.org, and by our incredible donors like yourself. You can hop on over to survivingbreastcancer.org to sign up for our mailing list, make a donation, and explore the 400 plus programs we offer each year at survivingbreastcancer.org/events. Until next time, keep on thriving.